Welcome to Healthy Buzz, the podcast for women who are craving honest answers in a supported community. Hosted by Brandy Homerding, a certified nutrition therapy practitioner who believes your body isn't broken, but the narrative around women's health is. Each week, we're diving deep into holistic health topics, challenging the one-size-fits-all approach, and empowering you to trust your own informed intuition. Get ready to feel seen, supported, and seriously informed. This is Healthy Buzz, where collaboration meets unfiltered transparency in women's health. Hi, Healthy Buzz listeners. Before we begin this episode, please be advised that we will be discussing sensitive topics, including eating disorders, disordered eating, and body image. If you or someone you know are struggling, please put your well-being first and maybe go ahead and skip this episode, or reach out to your professional for support. We have included some helpful resources in the show notes. For today's topic, we are going to be talking about something that is quite fascinating and I think can affect almost everybody in some way, shape, or form. We're going to be talking about disordered eating and eating disorders. And for today's topic, I am joined by Dr. Samantha Turetsky. She is a licensed clinical psychologist and private practice owner. She has over 10 years of clinical experience and specializes in treating eating disorders, overcontrol, loneliness, and perfectionism. She's passionate about helping women advocate for equality within their relationships, set boundaries to help them feel left overtaxed, and recognize unconscious patterns that may be sabotaging their peace. Welcome, Samantha.
Thank you so much for having me. I'm so excited to be here today.
Yeah, so to start off, I would love to hear more about your journey and how you got involved in this work.
Yeah, absolutely. So I wish I could say it started in grad school when I was first doing my therapy experience and that I knew about it the whole time, but unfortunately that wasn't the case. We don't get a lot of training specifically on the subject of eating disorders. It's not talked about very much at all, at least it wasn't in my grad program. So it first came on my radar when I was actually doing my postdoctoral fellowship. I was doing my postdoc in a private practice, and the practice owner was one of the premier eating disorder specialists in the Tampa Bay area, which is where I did my postdoc. I lived in Florida before moving to Washington. And that was my first experience with eating disorder assessment, diagnosis, even knowing what questions to ask potential clients. And once it came on my radar, I was like, oh my God, I've been totally overlooking a really important component of assessing any new client because it is so common and so prevalent. And so since then, I've really wanted to raise awareness about this since it's something that most clinicians, I think, are just not trained in, unfortunately.
Yeah, so with that, how did the practice kind of then evolve? Were you seeing more clients show up and presenting with some of the things that you learned during your training and where you're like, oh my gosh, this is happening a lot more than what maybe we realize?
Yeah, definitely. I mean, the practice where I did my postdoc, we specialized in eating disorders and trauma and depression, a couple other things. So we had people explicitly coming for treatment, but even those who were not coming for the subject of eating disorders, once I knew how to assess, what questions to ask, most people have some kind of, we can use the term disordered eating, which we can define kind of the difference between those two, but something going on with food. It's at least relevant to ask. I would say for clinicians, every client you might encounter, it's worth assessing for because if there's things going on, it could affect general cognitive functioning, energy levels, symptoms that show up that look like other things could be explained by someone who's restricting or binging and purging. So it's important to know about. It's important to know what to ask.
Yeah, I find that even in the work that I do, understanding somebody's relationship with food and if they've had an experience or a part of their life where they did have some eating disorder or disordered eating habits, that getting them to the right professional to help them, because that's really beyond the scope of my practice too. But getting them in contact with somebody who can help them navigate through maybe some of their different situations with their relationship with food. It's so personal.
It is. It's so personal and it's so complex that if one of the primary concerns they're coming in with, whether they knew about it or not when they first sought treatment, is an eating disorder, it's important to work with a specialist. I can't emphasize that point enough, just because there's things that people with experience and specialties in this area know to ask or dots to connect that might not be obvious to someone without the training.
Yes, absolutely. So with eating disorders, there's kind of like this pervasive and oftentimes damaging narrative around eating disorders. How would you define an eating disorder? And maybe we can also expand that to like, what is an eating disorder versus disordered eating? How are they similar? How are they different? How do we differentiate them?
Yeah, absolutely. It's a great question. The clinical definition of an eating disorder, which is kind of jargony and then we can break it down, is a persistent disturbance of eating or eating related behaviors. And this disturbance leads to altered food consumption or absorption, resulting in significant impairment or physical health or psychological functioning. So to break that down, that can be persistent disturbance, meaning like could be a preoccupation with food, like how much you think about food. It could be rituals you have around how you consume food, rules you have around the types of food that you deem okay and not okay to eat. And so, to meet diagnostic criteria for an eating disorder, there are some specific things to know about, and they vary between different types of eating disorders. The most common that people have heard of is anorexia nervosa, bulimia, and binge eating disorder. There are a few others as well. But disordered eating encompasses any unhealthy food and body behaviors, which are usually undertaken for weight loss or health promotion, but not always. And that can lead to significant harm. That's really the definition. So that's a pretty broad term. Harm can mean and look a lot of different things, different ways. But some examples of this might be like chronic dieting, rigid food rules, maybe anxiety about eating, either by yourself or anxiety about eating in front of other people, being watched and observed, preoccupation with food and body image, and like even some behaviors that we've been told are healthy or that are even endorsed in some wellness spheres, like calorie counting, like keeping track of macros. Some of these things can be, for one individual, totally not harmful and not lead to any problematic areas. And for other people, depending on who they are and kind of how they're wired, these things can be really slippery slope and lead to potentially a full-blown eating disorder. So it's good to be cautious about the behaviors you're engaging in and really kind of taking an honest assessment of how are they affecting you and how much space are they taking up in your brain.
Yeah. So what I'm hearing is that like the disordered eating habits could become a eating disorder, like a slippery slope. Whereas if it becomes way over consuming of your life and causing all these different disturbances and impairment, like the preoccupation and the rituals and all these really, really rigid, strict rules, that could be kind of some warning signs that like, oh, maybe we need to assess and work with the right practitioners to understand what the relationship with food looks like.
Totally. Because one of my favorite things to say as a therapist that applies in so many domains is that context matters. And so if we're able to do things in certain contexts, if you're able to, I prefer to eat certain types of food or a certain way at home, cool. But if we're extending that to all of the context in our life, now I'm, only ordering certain things at restaurants, or people bring food to a restaurant because they don't want to eat the restaurant food. Like now we're kind of bleeding into broader context in our lives, and that can become really impairing. And food is such a social thing too. Like we humans connect over food. Food can represent social celebrations, religious celebrations, like marking milestones. Food is a hopefully multiple times a day part of our life. And when we start to get really rigid and put a lot of rules on it, it can be really impairing for in so many ways, including socially.
Yes, absolutely. So, could you? I was wondering because you mentioned this a little bit earlier that there were three main different types of eating disorders that you typically work with that are the most common. One was anorexia, bulimia, and then was binge eating. So, could you describe those for our listeners so that they can understand the difference between those? Because maybe they don't understand how they are different, but all can be disordered eating.
Yeah, absolutely. So, anorexia, officially the term in the DSM is anorexia nervosa, is a restrictive eating disorder, meaning that it involves not eating enough. And restriction can look a lot of different ways. I think people stereotypically think of restriction as someone who like does not eat or eats very, very little throughout the day. That could be the case, but restriction can also be people who are eating maybe at regular intervals, but the calories and the content is so restricted they are not getting the nourishment that they need. Something important to note with anorexia that's, I think, a common misconception is people think anorexia is only people who are really underweight, and that is a specifier for a diagnosis of anorexia nervosa is being underweight. But there's a separate diagnosis called atypical anorexia, which is all of the same criteria for restriction and impairment of functioning that comes with typical anorexia without the low weight specifier. So you can actually have anorexia and be at a quote unquote normal or even higher weight. So you can see people in really larger bodies, which that is the term that we use in the eating disorder community. We don't say like obese or overweight, stigmatizing words, just a neutral descriptor. People in larger bodies can also have anorexia. And that's something that blows a lot of people's minds when they hear it, because a certain image comes to mind when you think anorexia for most people based on media. So you can be actively restricting and at any body size.
Yeah, that's good to know, because a lot of times people have the misconception that like only people in smaller bodies can have an anorexia diagnosis.
Totally. And this is where we might see weight bias come up in providers who aren't trained in this, is that if they see a client presenting in a larger body, it may not occur to them, just because of assumptions we make, not because anyone is, malicious, to even assess for relationship with food, or certainly not restrictive relationship with food. Another part about anorexia to note is that there are two subtypes for anorexia. One is purely restrictive, so just not eating enough to sustain a healthy body weight. And the second is anorexia binge purge subtype. So there is actually a diagnosis of anorexia that involves binging and purging. A lot of people don't know that. And so this is where diagnosis gets super duper tricky, because if you don't know exactly the right questions to ask and the right assessments to make, one thing could look like another, and the treatments can be pretty different, which we can get into a little more later. So a lot of nuance there, even just among one diagnosis.
Yes, absolutely. So then can you explain what bulimia is?
Yes. So bulimia is an eating disorder that involves more common binging and purging without the restriction component. And so something that is really an easy way to think about binging, because I think this word is used a lot and can be used in times when it doesn't really clinically apply. People might kind of casually say, oh, I binged last night, like I was so bad, or whatever that sounds like. And so clinical binges are actually really a large quantity of food. And so this is the way I explain it to patients to kind of get a sense of, are we talking about a true objective clinical binge or a subjective binge, which feels like a binge to you, but might not actually be a clinical binge. So during a binge episode, which typically the DSM specifies in a 2-hour period, is the quantity of food that you ate. If we took all the food that you ate during a binge, laid it out on a table, and pulled 10 random people off the street and asked them, what do you think about this quantity of food? For a subjective binge, which is not a true binge, those 10 people might kind of agree, like, I mean, it's a lot of food, but like I've eaten that quantity of food when I've been really hungry, or like I could see myself eating that quantity of food at some point. That's not out of the realm of possibility for me. Whereas if it were a true objective binge, clinical binge, those 10 people would be like, I have never eaten that quantity of food in one sitting and probably could not. So that's kind of a helpful distinction between subjective binge and an objective binge. And the other qualifier for a binge is that the person feels out of control and unable to stop while they're in the middle of it. So even if they have awareness of like, ugh, this isn't in line with my values, or I have awareness that my body's probably not going to feel very good after this, they kind of feel unable to stop themselves. And so that is the binge component of bulimia. And then the purge component is purging, ridding yourself of what you've eaten after. And that can look a lot of different ways. Stereotypically, I think the inducing vomiting is what comes to mind for people, but it can also be any other kind of compensatory behavior. Compensatory meaning to compensate for the food that you've eaten. So that could look like using/abusing laxatives. It could be compulsive exercise, secret exercise, like being alone in your room and doing a really intense workout. So there's a lot of ways that people engage in compensatory behaviors after a binge. And in general, compensatory behaviors is something to assess for when we're talking about any kind of disordered eating or eating disorder. And this probably resonates with a lot of people, a lot of listeners, of just like, oh, I feel like I've been quote unquote bad. We'll talk about language a little more in the episode later, but I feel bad about what I've eaten. And so I need to do XYZ to compensate, whether it's not eating something for the rest of the day or the rest of the week, or engaging in exercise, or some other kind of compensation.
So then in what ways does that differ from binge eating disorder?
Yep. So the primary way that that differs from binge eating disorder is that with binge eating disorder, there is no compensatory behavior afterwards. There's no purging behavior afterward. It is just a pure binge.
That's really helpful to know the differences between those main three. Now, there's another one that gets thrown around a lot in my space, in the wellness space, and that's orthorexia. Is that something that you would like to expand on for us?
Sure, absolutely. So interestingly, that is not a diagnosis in the DSM-5, our kind of diagnostic manual, but I think it is worth speaking about because it's kind of in the same way that disordered eating doesn't have its own section in the DSM, but is super common and prevalent. Orthorexia is kind of the same way. So my understanding of orthorexia is it is a hyper focus on clean, quote unquote, clean and healthy eating. And so it often comes with a lot of the food rules. There's the eating component of it as well as the often compulsive exercise component. And so I don't know why orthorexia is not in the DSM, because it feels like it's so common that it would be relevant to add so that it would get some clinical legitimacy, and maybe so we can do some better research to determine effective treatments for it. But yeah, I think we see this on display a lot in wellness, fitness, influence spaces of people really actively endorsing orthorexia as a way to change how your body looks, change how you feel in your body. And I think it's that slippery slope piece coming in again of like, for some people, they might be able to engage in some rigid behavior and not have it impair them too drastically. And for others, it can set off a really damaging chain of events that could affect the rest of their lives.
Yeah. And so how I see this showing up in my space is like, let's say somebody had food sensitivity tests done and they had all these different foods that showed up as inflammatory for them. It's a slippery slope. And so this is often, and I had a conversation with somebody else recently on the podcast about, are we doing food sensitivity testing or not in our practices? And if somebody has a past of disordered eating or eating disorders, that's a hard no for a lot of the people that I know in my space. But because it sets these like new rules, and sometimes people think that these foods are now inherently bad, and that's not necessarily the case. Now, there are times in which we can use different dietary strategies to support somebody's overall health, but it can be that really slippery slope. So I can oftentimes work with people who are like, I had these food sensitivities 20 years ago and I haven't had chickpeas since. And I'm like, well, if you've done a gut healing protocol, chickpeas should be able to come back into your diet. And so like eliminating some of that like fear around like, I'm going to eat chickpeas and I'm going to have all these GI symptoms again, is like, we got to like retrain some of the mechanisms, the beliefs, and like actually prove to yourself that like, hey, actually chickpeas are not causing me any distress anymore in my body.
That is such a good point. Thinking about how that applies with orthorexia, there's so many wellness trends that involve eliminating huge aspects of food from your diet. Eliminating gluten is a completely life-altering thing to do. So you raised such a good point about how if we're doing that for reasons that aren't actually medically necessary, we could be adding in a really restrictive element to our life that doesn't need to be there, or is maybe there for very much the wrong reasons, or for pseudoscientific reasons, even possibly.
Yeah, absolutely. So you hit on one of the myths around like certain body sizes indicate certain eating patterns or habits with people. What other harmful myths or misconceptions are there out there about eating disorders?
Yeah, so many. Great question. I want to add a statistic on to what I shared earlier about how you can't really tell by kind of looking at someone's body size whether they have an eating disorder or not. 94% of individuals with eating disorders are not considered medically underweight. So we're not talking about
Wow.
some people, we're talking most people who meet criteria for an eating disorder are not underweight. So We really cannot tell by looking. You can't judge a book by its cover there. Another common myth is that only white girls from the suburbs get eating disorders. And we think only certain demographic groups can get eating disorders, and that is not true. Any demographic, any race, any socioeconomic status, any sexual orientation, any gender, eating disorders are still more common in women, but they certainly exist in men. So eating disorders can appear in any population, which again is why I mentioned assessing any client you encounter, regardless of what they're coming in for, or even if they initially say, oh no, eating's fine, and kind of gloss over it, I still like to ask a few, maybe not even in the intake session, but just kind of keep it on my radar to make sure that nothing's going on. Because if you're engaged in disordered eating and it's just a part of your life and you don't know about it, it might not register. You might not think to say, yeah, I have some issues in my relationship with food. Another reason that working with a specialist can be helpful if that is going on. Another common myth when we're talking about teenagers is that if we see teenagers, dieting or kind of having some negative body image stuff come up or expressing desire to lose weight, we might brush that off and say, oh, that's just a phase, or it'll pass, they'll grow out of it. Really important to know not to dismiss this as a teenage phase. It's a really concerning red flag to look out for if you see kids, teenagers, young people endorsing wanting to lose weight. It doesn't automatically mean that we have an eating disorder or like a crisis on our hands, but it's certainly something that warrants attention and questioning and curiosity by parents to get a better sense of what's going on, and even potentially might warrant some monitoring, some extra kind of vigilance around noticing how your kids are eating or what they're eating, because what some people might write off as a phase could be the start of disordered eating behavior or an eating disorder. And kids growing up should be only gaining weight, right? Like as kids move from babies to toddlers to children to adolescents, we should be heading in an upward trajectory on weight. And any loss, any lapse, any stagnation is cause at least for curiosity, because kids should really only be gaining weight, not losing weight, as they are making more of themselves and growing bigger and taller. So that's something really important, especially for parents to look out for, or anyone who interacts closely with kids.
Yeah. I think something that's really important to say about that too is like a lot of adult women maybe don't have the best relationship with food, and maybe they're projecting some of their own like habits and insecurities onto their younger kids who are picking up on those signals, and then that's just like perpetuating this cycle around an unhealthy relationship with food.
Absolutely. And in the same way that physicians and other medical providers can have weight bias, parents are not immune to weight bias either. And so if we think in our minds that, oh, maybe my kid's looking a little bit chubby and I wouldn't mind if they lost some weight, it's certainly maybe something to trigger some inner reflection about our own weight bias. And I'll use the term fat phobia too, which sounds a little intense, but is really just a societal thing that exists in our world, that we tend to have all sorts of negative connotations with anyone we might deem fat or in a larger body. That can definitely bleed on to kids, unfortunately. And so it's really important for anyone who has kids or is considering having kids to examine their relationship with food and body to make sure that they're not passing on some not so helpful behaviors, even inadvertent or indirect or nonverbal behaviors around food, like a raised eyebrow when your kid goes back for seconds, or are you sure you are still hungry? Like these things that might seem really innocuous. I mean, it's so tough to be a parent. I have so much empathy for how hard it is. I'm not saying micromanage every word that comes out of your mouth, but these things would be helpful to think about, especially when we're raising kids who are really susceptible to absorbing all of the things that they see, hear, and have modeled to them.
Yeah, yeah. I mean, I've worked with clients too who like remember like, oh, I was put on Weight Watchers when I was 8 years old. And I'm like, oh, that just breaks my heart. Or like when I sat down at the dinner table, I got served smaller portions. And I'm just like,
Yep, I have heard all of those things too. And something else we know about eating disorders is that the sooner they are detected and treated, the better the prognosis is for full recovery. And so for the kids who got brought to Weight Watchers at 8 years old and are not seeking treatment until they are adults, in their 30s, 40s, 50s, older in some cases, that has been wired and solidified into their brain, into their cognition for their entire life. Their chances of recovery are lower, unfortunately. And so that's another reason why catching, detecting, treating eating disorders early for kids is really important, because it gives the best prognosis for full recovery.
Yeah. I will say one of the best books that I read when talking about like how to have conversations with your kids about weight inclusiveness is a book called Fat Talk. Have you heard of that book?
I haven't.
It was really good. I listened to it on audio and it was so good about like rewriting this narrative around fat and how we are all different sizes, shapes, and we have different needs and how we can include everybody. So I highly, highly recommend that book. We'll put it in the show notes with the author's name as well so that people can check that out. But one thing that I want to also ask about, because I think it is a misconception, is that eating disorders only start in like children or teens or maybe even 20s. And can you expand on like how everybody is really susceptible to at any age an eating disorder?
Yeah, absolutely. Like we were talking about earlier, there can be certain events that can happen at any age. I've had clients who were chugging along just fine, had no issues with food and body, and then they might have gotten into a friend group or dated someone who had some orthorexic tendencies or their own eating disorder tendencies, and that set off like they're doing this thing, let me try that. That can set it off, depending on what's happening in our lives. If we are busy kind of grinding it out in school and work and we don't have time to think much about other things, and then we finally get to a stable place and we might have a predisposition towards taking a deep dive into things, or a tendency towards perfectionism. Maybe we'd been applying that to, school and work before, and now, we have this free time to apply it to a different area of our lives. It can take a turn that way.
I can see it also show up when somebody is feeling like a lack of control in their life. The world is kind of chaotic right now.
Yeah.
So,
putting it mildly.
right? So it can show up as like, oh, I can control. This is one thing in my life that I can control is the food that I'm either allowing in my body or not allowing in my body, and how I move my body or not move my body. And so it can become this control issue. Hey, Healthy Buzz listeners, are you feeling like you're constantly struggling to hit your protein goals? Like, you should be getting more protein for energy, muscle support, and overall well-being, but you're not quite for sure how to make that happen without sacrificing flavor or other important nutrients. I get it. That's why I created the High Protein Power Plan, a delicious and easy to follow 7-day meal plan designed specifically for women who want to effortlessly reach 130 grams of protein or more every single day. Now, this isn't about bland chicken and broccoli. Inside, you're going to find mouth-watering recipes packed with flavor and designed to perfectly balance your macros. Think vibrant salads with protein powerhouses, satisfying bowls packed with flavor and nutrients, and easy dinner ideas that make hitting your goals a breeze without feeling deprived. This plan takes the stress out of high-protein eating and helps you feel your absolute best. Ready to finally unlock the power of high protein without the guesswork? Head on over to bcw.bcollectivewellness.com/high protein recipes to download your high protein power plan today. That's bcw.bcollectivewellness.com/high protein recipes. It's time to nourish your body, feel amazing, and discover how delicious hitting your protein goals truly can be.
That's a great point. That makes me think of even an event like the death or a loss or grief could potentially trigger some disordered eating from that control perspective too.
So I know your work specializes a lot in like over control, rigidity, and perfectionism. So how do these traits often overlap with both eating disorders and high functioning anxiety? How does the drive for control show up in a person's relationship with their body, food, and ultimately other people?
So let me first define what over control is before we get into how it connects. So over control is not a diagnosis. It's not something you'll find in the DSM. It is a style of coping, and it tends to be wired in us from birth. And so it's very related to self-control, which is usually a good thing. Self-control is often helpful. It's adaptive to help us reach our goals. Over control is maladaptive self control. It's basically having too much of a good thing. And so, for someone who's over controlled, their kind of tagline phrasing is when in doubt, apply more self control. It's often associated with social isolation, loneliness, poor interpersonal functioning, and often severe and difficult to treat mental health problems, one of which is anorexia nervosa. And so, we can think about this from a delayed gratification perspective. For someone who doesn't have an eating disorder, the idea of fighting through your body's signals that it's hungry and, kind of like feeling that sensation in your stomach, the gurgling, it's kind of impossible sometimes to imagine how someone could have the, hesitate to use the term willpower, but the ability to ignore those cues and choose not to eat. And so this is where that maladaptive self-control comes in, of we're kind of using something that can be used in really positive ways in ways that are really harmful to us.
So then how does over control and like perfectionism, how do those traits then overlap with eating disorder? Because I do think that was really helpful to explain like over control and what that actually means.
Over control specifically is most relevant to anorexia. And in fact, there's a therapy that I'm trained in called RODBT, which stands for Radically Open Dialectical Behavioral Therapy, which doesn't explicitly target any kind of talk or language around eating disorders, but it targets over control and kind of the secrecy, the hiding, the shame that we often see with anorexia, because anorexia is not happening really out in public. Most people are not publicizing what's going on for them, and they're not open, or at least they're probably attempting to obscure the restrictive behavior they're engaging in. And so it's really interesting that we have a therapy that is not really explicitly designed for eating disorders, but actually targets anorexia, because a lot of times for bulimia, for binge eating disorder, we use other types of therapy like cognitive behavioral therapy that challenge thoughts and behaviors and emotions and how they interplay. But with anorexia and over control specifically, we're actually targeting things like more open emotional expression, ability to be more vulnerable with other people, and ability to socially signal in ways that allow us to be more connected with other people as a treatment for the restriction, which I find really, really interesting. It was kind of groundbreaking to learn about this therapy and how effective it can be for treating anorexia.
Wow, that is fascinating. So a lot of people that I work with would describe themselves as like very type A and very perfectionist. And they like when they start working with me, they'll be like, I just need you to tell me what to do and I can check all the boxes. I'm like, that's not how this works. I'm going to guide you, I'm going to offer you support, and we're going to do resources. But I'm also not the person that's going to tell you what to do. I need you to have a little body autonomy here and start to learn the signals that your body is giving you. So with like high achievers and people who are really tying in like their self-worth to like productivity and the ability to adhere to a very perfect diet or fitness routine, what shifts needs to occur for people so that they are maybe less driven by metrics and more into like leaning into their body and what it actually needs?
Yeah, that's a great question, because when we are thinking about the pursuit of perfectionism, if we think about it logically, there really is no such thing. And so pursuing flawlessness, whatever people imagine that to mean, or whatever altered images we see presented of that on social media, it's just not achievable. And so we get into a place where the goalpost is constantly moving. It's really interesting when I have clients who finally move into recovery and are kind of reflecting back and looking at their past and where their brain was when they were actively in their eating disorder. They're like, oh, I'm looking at pictures of myself from when I was in my eating disorder. For people who were underweight at the time, I thought I looked incredible. And now, from a healed brain looking backwards, I can see that wasn't necessarily the case. And so having an eating disorder can really alter our perception of things. And so one way to move away from that is values. Thinking about if behaviors you're engaging in aligns with values and goals that you have for yourself. And this can apply to goals with your health. It can apply to goals with your body. It can apply to goals in relationships. Because so many times when we're actively involved in an eating disorder, we are pursuing that as our primary outcome, and we might not realize how impairing or how harmful they can be to our relationship quality. And so thinking about, how do I want to show up for myself, for my kids, in my job, in my relationships, and how is pursuing perfectionism working for me? Is it actually helping me feel more satisfied and happy in my life? Or am I finding that it's leading to kind of a cycle of harsh self-blame and inner criticism that is not actually helping me reach the kind of life I want for myself or the kind of relationship I want for myself? And so the pursuit of what I call psychological flexibility is helpful for everyone, but especially relevant for people with an eating disorder, which often involves rigidity, not taking into account the context, having a rule that applies no matter what the time of day, no matter how I'm feeling. This can apply a lot to exercise. If people have a rule around, I need to exercise a certain amount of times per week, but I'm on my period and I'm feeling like shit, or I didn't sleep well last night and I don't have the energy to do it today. Psychological flexibility is allowing yourself the grace to say, okay, you know what? I need rest today, so I'm going to take the day off, rather than, I said I was going to exercise 5 times this week and I have to do it no matter what. And so it's really beautiful to see clients shift from external metrics like number of times to do something or grams of protein that I'm trying to eat in a day, to honoring what they need and the ability to look inward to assess even what they need or how they're feeling to determine their next move.
Yeah, that's such a huge part of it. I love that phrase of psychological flexibility. It's like the end. I can and I can. Like it's not an or I have to. Both sides of the coin can be true at the same time. That yes, I can move my body today because I am capable, and I can rest my body today because I'm not feeling as energized. And so it's listening to what your body actually needs and is telling you. And that's so hard for so many women. It's scary for so many women to listen to what their body needs and to tune into the signals it's giving them.
Absolutely. I think we cultivate a distrust in our bodies pretty early on, especially for women, of push through the pain, or maybe you've had your pain dismissed or your symptoms dismissed by medical professionals. That's not going to cultivate trust in your body and your symptom. It's going to cultivate a lens that looks externally to determine what we should do or how we should treat ourselves. And so, something I'm really passionate about in eating disorder work and not in eating disorder work is helping women turn up the volume on that inner compass, that inner voice that allows them to make decisions that are actually context relevant, values oriented, and right for them, rather than what they're being told they should do externally or what they're imposing on themselves internally.
Yeah. And I think this leads into that thing that you alluded to earlier around language, the language that we use, and oftentimes like good and bad and a little bit around that. And it sounds like this plays into a little bit of that psychological flexibility. Can you explain a little bit more about language and how that can influence like our relationship with food and ourselves?
Yeah, I love language as a therapeutic tool. I give that as a disclaimer to any clients I'm working with, that this might sound a little nitpicky if I'm poking on certain words that you're using, but I am a firm believer that the language we use to think to ourselves, talk to other people, plays a huge role in shaping the way we feel. And so language is particularly relevant in the field of eating disorders when it comes to food labels. And so most of us have grown up hearing women or people in our lives saying, oh my gosh, I was so bad. I ate dessert twice this week. I was bad. Think about what messaging that sends to someone who's hearing it. Oh, if I eat certain foods, I can either be good or bad, moral or amoral, worthy of love or unworthy of love. You know, it goes really deep. We can take it to places that maybe it wasn't even intended to go by the person who said it. And so one of the big shifts I recommend to clients slash anyone who lives in this world, I'm going to say I recommend it for everybody, is really starting to become aware of, because that's the first step to changing anything, is having awareness of it, and then making shifts around language that you use, both to think to yourself internally and talk out loud around food. And so moving away from labeling foods, and by labeling I mean putting a good or bad connotation on it. So some labels that are really common for foods that are not so helpful are junk food, garbage, empty calories, fried foods, fattening, all these kind of stigmatizing words to label food. And I can dedicate a whole session to an exercise of brainstorming more neutral, just descriptive words to describe food. So shifting from, oh my God, that cake was so fattening, to, wow, that cake was really dense. Something can be dense without being bad or good. And so descriptive words like crunchy, salty, creamy, rich, dense, light, all these things can be different ways of describing food without necessarily putting a moral or immoral connotation on the food itself. Also, healthy and unhealthy. If we label something unhealthy, then, that comes with its whole host of connotations of, oh, I shouldn't eat too much of it, or I'm bad if I eat it, or I'm weak if I eat it. All these different kinds of things. And so instead of thinking in kind of black and white terms about whether a food is healthy or unhealthy, you can shift to thinking about what your body needs, what your day looks like, and choosing foods that will fulfill those kind of goals for you. So if you know that you're going to be out for many hours and you're not going to have access to a snack, maybe you pick a food that is higher in protein, that has enough calories to sustain you for that amount of time, rather than thinking about, oh, I need to eat healthy to prepare for my day, thinking about what kind of foods are going to fuel and sustain my body for this amount of time. If you're not going out anywhere and you are just hungry and you have the luxury to think about like, what sounds good to me right now? Picking something that way versus like, what is healthy, what is on my diet, what is going to make my body look the way I want it to, thinking about what's going to make my body feel the way I'd like to.
I love those shifts. Those are so good. And there's so much I want to say to this. One, I hate the term clean eating. Hate it, because what does that actually mean? There's so many different variations of clean eating, and I can work with clients who be like, well, I eat pretty clean. Well, what does that mean? Because some people that means I'm eating mainly fruits and veggies and animal proteins, or some people that could mean I'm just not eating gluten and dairy, and for some people that could mean I'm not eating fried food. Like, what does that actually mean? And the opposite of clean eating is dirty eating. Nobody's going to say, well, I'm dirty eating today.
That is such a good point, that thinking about any kind of stigmatizing label you put on food in a positive direction, whoever you're talking to may be thinking about, oh, I didn't do that, so now I'm the opposite of what that word is. Clean and dirty is a great example of that. And so even if something isn't overtly upsetting to you or not triggering to you, that doesn't mean that the language you're using might not be unintentionally harmful to somebody else.
Right, exactly. And the other thing that I think of too is like sometimes I find that women like to announce things so that nobody is judging them, right? Like, oh, I'm eating this brownie, but I worked out this morning. Or, oh, I'm doing this, but, and then like we feel like we have to announce it to everybody and like justify
Totally.
why we're choosing our food choices. I remember one client I worked with who she's like, I have such a bad sweet tooth that every time that she would get something sweet at the coffee bar at work, she would announce it to everybody. Here's me feeding my sweet tooth, da 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 da. And I was like, we don't need to make an announcement. Like, we're so afraid that other people are going to judge us that if we announce it and we make it our identity, then people will be less judgy. But the person who's judging you is yourself. Nobody judges you more than you yourself. Let these identities go.
That is such a good point. That was something that really stood out to me once I kind of got this information and started seeing this. It almost felt like taking, I don't know if it's the red pill or the blue pill in the Matrix, but like once you learn about eating disorders and you kind of have this veil pulled back, you recognize around you, especially in groups of women, men are less likely to do this just from my anecdotal observation of how often women are announcing it, talking about it, labeling themselves before someone else can label them. Oh, I know I'm being bad. Oh, aren't we so bad with this? I made a choice once I learned about the harm that talking about these things can do to kind of stop engaging in that conversation. And it really stands out. I'm kind of on the outside when I'm in a group of women who might not be as aware of these things. And it's shocking how common, how prevalent, how built in this kind of conversation and language is and normalized it is in our society.
Yeah, absolutely. So I know another thing that you work on extensively with your clients is boundaries. So, what is a simple definition of boundary, and in what way do boundaries maybe help us when we think about like our relationship with food?
Yeah. So often people think setting a boundary means telling other people like how they can or can't treat them. And actually, what a boundary is letting people know, hey, if you engage in this behavior, this is how I'm going to respond. Because we can't control anyone. Even if we make requests and express preferences of how we'd like them to talk to us, it's not a guarantee that they're going to follow that. And so a boundary is not, hey, you can't talk to me like that. It's, hey, if you continue to raise your voice with me, I'm going to leave the room. So that's really important and something I like to clarify with clients because we're not taught in schools what setting a boundary looks like or how to do it effectively, or the fact that oftentimes setting a boundary one time is not going to lead to behavior change for the other person. You often have to implement what I call the broken record technique of restating your boundary many times and importantly, following through, right? If you say you're going to walk away if someone talks to you in a certain way, you have to walk away for them to learn that they can't speak to you that way. And so it's really relevant for some of the behaviors that, again, have been normalized in society, like commenting on people's bodies, commenting on the food that they're eating, commenting on if they've gained or lost weight. So, for example, a lot of us have grown up in families where it's normal to remark on your parents or your child's weight, like when you see them for the holidays and it's been a few months. Oh, you look great. Have you lost weight? Or the opposite, right? Which is not, no one is immune to, unfortunately. And so, a boundary that a lot of clients set, a boundary that I've set in my own family is, hey, I'm not open to comments about my body. Any comments about my body, whether you think they're complimentary, whether you think they're trying to help, whether you think you're looking out for my best interests, I'm not open to comments on my body anymore. And that was a big shift. A lot of us grow up in families where that's completely normal. Even if it is coming from a place of love, it's an important shift in our self respect and ability to have autonomy, to live in our bodies free from remarks, criticism, judgment. The peanut gallery is not open for commenting on our food or how we look. So that's one that is a good place to start.
Yeah, I have that with clients a lot too. And they will talk about, like, my mom always comments about weight. We always get on the conversation about weight and it doesn't feel good anymore. And I'm like, you need to speak up. And it's time to say, look, I hear you. And maybe thank you for your concern. I'm not interested in engaging in this conversation with you. I'm not having this
Yep.
discussion with you. And you have to reiterate, like you said, broken record. You're going to have to say it again. Thank you, not interested. Thank you, not having this discussion with you. And that comes with a lot of things, not just body, but like in general, if you feel like something is, I guess, like encroaching on your personal beliefs and boundaries, and you feel like it's going to cause a lot of conflict and negativity within you, it's okay to be like, I'm just really not interested in having this conversation with you. And some might say that makes you close minded, but I would say it's protecting you and yourself.
Absolutely. And something else I encounter a lot with clients who are attempting to set new boundaries is it elicits a lot of guilt in them when they're asking people to change their behavior, or, it's been normal to do something in your family as long as you've been alive. And now at age 40, you're asking it to change. We don't wait for a time that we're not going to feel guilty to set the boundary. We anticipate in advance that setting the boundary could elicit some guilt, could elicit some defensiveness, some tantruming, whatever kind of response we get. That doesn't mean that the boundary isn't valid. That's a pretty common reaction to asking people to change behavior that they didn't know was problematic before. So I just want to emphasize that we don't need to wait for a time that we're not going to feel guilty, because that time is not going to come. Setting boundaries is difficult because it involves pushing through discomfort and guilt, oftentimes, especially for women who feel like they're might be responsible for other people's feelings or well-being, to ruffle some feathers, and that's okay.
Yeah. So, what does a treatment for an eating disorder look like?
Yeah. So a lot of times people don't get a diagnosis until they present to therapy, or they might present to therapy with someone who doesn't specialize and get a referral. Hopefully, ideally, get a referral to a specialist, but a lot of times that doesn't happen. Unfortunately, less than 1/3 of people who have an eating disorder ever actually get treatment. And that is a very low number for a mental illness that is the number two most fatal mental illness behind opioid addiction. So, eating disorders
Wow.
are actually very dangerous and can often be lethal, especially in the case of anorexia. So hopefully someone recognizes or a loved one speaks up that they have a concern and that person seeks treatment, typically outpatient treatment, like showing up for a weekly therapy session. However, another reason that working with a specialist is important is sometimes, depending on the chronicity, severity, and medical stability of the person presenting for therapy, sometimes outpatient therapy, where you're meeting kind of traditionally once a week, is not enough. So I always tell my clients that a requirement for outpatient treatment is medical stability. So if you are having fainting spells, if you are unable to regulate your body temperature, if you are having a lot of lightheadedness and passing out upon standing up, which these are things that can happen when we are chronically or at any point malnourished, you are not an appropriate candidate for outpatient therapy, and you should hopefully be referred to a higher level of care. And so when I say higher level of care, there are 3 levels up from outpatient therapy, and all of them can be relevant at different times depending on the severity of the eating disorder. So the first step up from outpatient care is what's called intensive outpatient, or IOP, and that can, now in the age of Zoom therapy, sometimes that can be virtual or in person, and that is usually 9 to 12 hours a week of additional therapy. That can be usually like 3 or 4 days a week, 3 or 4 hours per session of additional care. And that can look like art therapy, group therapy, family therapy. There's lots of different programs. It's actually quite challenging to find a good fit for you. And so it's definitely recommended to seek professional advice and consult to determine best fit of program. The second step up is what's called PHP, which stands for partial hospitalization, which you can kind of think of that as like attending a job. That's 5 days a week, 8 to 9 hours a day, where you are showing up to a facility for treatment, eating disorder treatment that looks in all the ways that we talked about in IOP for 8 hours a day. And then the final level of care is residential treatment, where you actually attend treatment throughout the day, all day, and also live at a facility. And people have all sorts of negative connotations with higher level of care. Teenagers especially like feel very threatened, or like think that it's being used as a threat, and conjure all sorts of images of like fluorescent lights and, like padded walls and all these things we think of kind of movie wise when we think of being institutionalized, and oftentimes can be really, really nice hotel like facilities. And so I guess I'm wanting to communicate to not rule out and not stereotype what these higher level of care options can look like, because sometimes if an eating disorder has been present for decades and decades, 50 minutes once a week is not going to be enough. And so getting more intensive treatment, where we're also meeting with a psychiatrist to manage the medication or medical side of things, having frequent medical checks and supervision, ensuring medication compliance, and sometimes oversight is necessary. I like to kind of separate out the person, the individual, from their eating disorder, so much so that in outpatient therapy, I often have people give their eating disorder like a human name. So we can say like, hey, was this a you decision, or was this a, for example, like a Karen decision? Is this in line with what you want for yourself or what your eating disorder wants for yourself? And eating disorders can be very sneaky, very deceptive. Again, the person might not be sneaky or lying, but an eating disorder is willing to do anything to get away. And so sometimes, unfortunately, if parents aren't able to monitor full time or sit with their kids for every meal, or if an adult is left to their own devices and doesn't have anyone to be accountable to, it might be warranted sometimes to consider some of these higher level of care options. And it's never an easy conversation, but thank God that these exist for people who really need them. They can literally be life-saving in some cases.
Wow. Yeah, that is so helpful. And I love that you talked about like destigmatizing it, because we don't want people out there struggling. And I'm sure many people don't want their loved ones struggling too. And so finding the appropriate resource for you or your loved one's journey is really, really important to having that full recovery and living a beautiful and vibrant life.
Absolutely. Just as a final wrap up point, like a quick way to assess your own relationship with food, just a really quick and dirty tool to get a sense of, is this something that might warrant some extra care or concern in my life? Is the simple question of what percentage of your day is spent thinking about food, body, exercise, planning your meals, thinking about what I'm going to eat next, fighting off cravings. That's a really simple way to just get a quick sense of how much space this is consuming in your brain. When I have clients in active eating disorder, often their answer is 90 or 100% of their day is spent thinking about these subjects and planning around them and finagling how can I make sure that I get the exercise in while I'm trying to show my family that I'm in recovery, but I need to hide my exercise. And so just something I recommend checking in with yourself to get an assessment of where you're at in terms of how much this is taking up in your brain.
That is super, super helpful and a great thing for all of us to do a little self-check on, to be like, is this starting to cause a little disturbance in my life and my social activities and my family life and my obligations to work, family, organizations, things like that, and then seeking out the appropriate help. Well, this was such a great, insightful conversation. How can people connect with you? Where can they find you?
Yeah, absolutely. So I am working on getting my website up and running. But in the meantime, I have a profile on psychologytoday.com, which, if you haven't heard of it, is a great website to connect you with all kinds of providers, both psychiatrists, psychologists, couples therapists. And so I have a profile on there. Also, my email will be provided in the show notes. I am accepting new patients currently. So if you resonated with anything you heard today, definitely feel free to reach out. I offer free 15-minute phone consultations that are absolutely no pressure, just to chat and assess if we might be a good fit to work together. I have pages on Facebook and Instagram, Dr. Samantha Turetsky, Dr. Samantha Turetsky. Yeah, I would love to connect. I'm really passionate about all of the subjects we talked about today and helping women achieve more psychological flexibility, balance, and peace with their bodies. There are so many things in the world to focus our attention on, and I want to make sure that we have the capacity to focus on the things that are really important to us and not get kind of distracted by some of these things that are, I said I wasn't going to say the word, but tools of the patriarchy.
Yes, 100%. So before we part ways, quick question is, since you live in Washington, are you only seeing clients in Washington?
No, I am seeing clients in Washington and any other PSI-PACT state. So PSI-PACT is an acronym with a long name, but basically means that any state that has passed this legislation allows virtual reciprocity, meaning that you can see a therapist virtually. This applies to doctoral level psychologists only, I should mention, so not every therapist. But so I can see clients in 43 states. I believe Montana was just added as our 43rd state. So feel free to Google a list of PSI-PACT states, and if you live in one of those states, then we can work together.
All right, awesome. And if you have questions as to whether you live in a PSI-PACT state or not, just send Samantha an email and she can lead you from there.
Absolutely.
All right, well, this is a great conversation. Thanks for being on the show today.
Thanks so much, Brandy.
Thanks for tuning in to another episode of Healthy Buzz. I hope this conversation has left you feeling seen, supported, and ready to take the next step in your health journey. Love what you heard? Make sure you subscribe to Healthy Buzz so you never miss an honest conversation. And if you found this valuable, please take a moment to leave a review. I truly appreciate it. For exclusive weekly tips and holistic strategies, be sure to subscribe to my weekly newsletter. The link is in the show notes. Remember, this isn't just nutrition, it's permission to trust your body. I'll catch you on the next episode of Healthy Buzz.